Let's start this interesting session on the futures in anesthesia and ICU. We're waiting my co-chair, and okay, let's go. With pleasure, I introduce the first speakers, Professor Pinsky, talk about before hospital admission. Thank you so much, Prof.
Thank you very much. It's an honor to be here. It's a pleasure to see everyone in this room. And I was asked to talk about how I imagine the future before hospital admission. These are my conflicts of interest, and they relate completely to what I'm talking about. We have several patents and NIH grants related to the resuscitation of patients that are critically ill. Before I talk about what is the future, what is the present? And the present, there are several things that are happening. The vast, vast majority of the human population is not in the hospital. They're at home. And I'm not going to be talking about what we can do with ambulatory care, outpatient visits, e-visits that started out with COVID and they decided to keep them because they're working. They're really, the VA does robocalls to patients with diabetics that have potential for foot ulcers, and they ask them questions and they respond, and if it turns out they're saying something bad, within 30 minutes a nurse calls them and they've been able to cut by 1/3 the total number of diabetic foot ulcers. Okay, so these things do work and they're out there now, and we have targeted populations in which in the field they have special monitors at home. In the acute care crisis, when you get in an ambulance, unlike before, the ambulance drivers are trained, there are paramedics, and they are treating a very select group of people that are high risk for bad outcomes. And the number of things they can do is prescribed. It's limited, but they can do things like put in an artificial airway, start CPR, give IV fluids, and a few things like that. At the University of Pittsburgh, we have the largest air transport system in the United States. It's called Stat Medevac, and it uses very selective transfer of patients, and they can do things such as put in needle decompression for tension pneumothorax and other things as well. And it is that group that we are looking at to excitingly extend our pre-care. But what do I see as the future of pre-hospital care? I see the future as us grabbing the low-hanging fruit. And the two things that would be is early identification and treatment of sepsis and the appropriate resuscitation of sepsis based on the phenotype that the patient has. And the second one is advanced cardiovascular resuscitation using completely closed-loop resuscitation so that everyone else can deal with the concept of getting the patient to the hospital. Their resuscitation is going on its own. So, early identification and treatment of sepsis. Chris Seymour in our department was the head author in a paper in which they looked at the impact of the law that said that everyone that comes in sepsis in New York State has to get 1 hour and 3 hour bundles. And they showed that hospital mortality increased if you delayed those bundles. And as you can see in blue, this is the overall effect. The middle one is antibiotics, and the yellow one is for cardiovascular. But if you actually break it down, what you're seeing here on the 3 hour bundle is that if they delayed time to completion of it, as they progressively went from 1 to 2 to 3 hours and going up, mortality went up. And if you look at the starting of antibiotics, that is where the signal was. There was no effect. There was no effect of early resuscitation of fluids in survival of septic shock. All of the signal was due to the appropriate and early use of antibiotics. Who should we give it to? Well, Chris Seymour did a study with Matt Rosengard's lab in which they took mice and they gave them cecal ligation and perforation, and they noticed, and they watched them die, and they noticed there were two groups of patients of mice, one that had bradycardia, and they tended to die a little earlier, and one that didn't. So they took that data and said, okay, let's do a study in which we'll take all of the animals and we'll give some of them early fluids and some of them delayed fluids, and some of them early antibiotics and some of them delayed antibiotics. And we're also going to measure IL-6 as a measure of pro-inflammatory cytokines. Now, IL-6 is not a pro-inflammatory cytokine. I can give you boluses of IL-6 and it'll do nothing to you. But it's an excellent marker of the pro-inflammatory state, and IL-10, which of course affects white cells. And what they found is there were two classes of mice. There was a class 1, which we'll call the normal mice, but class 2 were hyperinflammatory. If you're a pediatrician, you know this. There's a group of people with septic shock that are pediatric that are hyperinflammatory. And then what they found was that the group that had hyperinflammatory, the group 2, as you can see, if they got early or immediate antibiotics, the solid blue line, they had improved survival. If it was delayed, it had worsening survival. But if you were in a regular group of mice that didn't have the hyperinflammatory response, it didn't matter whether you got the antibiotics early or late. Interesting thing, they found the exact opposite for resuscitation. In the earlier mice that were having the hyperinflammatory all the way over on the other side to group 2, if you gave them fluids early, they actually got worse. Whereas the normal mice that didn't have the hyperinflammatory states, if you gave them fluid, they got better. So how do I see this? I see the potential future that'll be, and this is being done now in clinical trials, but I don't have those data to share with you. Chris Seymour will do that probably next year. I will think we will identify in patients that are septic or septic shock using the SEP3 criteria, and we'll do point-of-care measurements of lactate, IL-6, and IL-10, and the ones that are high in IL-6 and IL-10 will get blood cultures and start on broad-spectrum antibiotics, and the ones that are low will give them resuscitation as they are being driven to the hospital. Let me now move to resuscitation from trauma. The University of Pittsburgh has published many papers, mainly in the New England Journal and JAMA, on resuscitation in the field, showing that if you do resuscitation with blood and plasma, and you look at evaluate the time that it took to start, how long did you delay resuscitation? The longer you delayed, the higher the mortality. So earlier resuscitation saves lives in trauma patients, okay? And so what we're going to do is I'm going to show you a picture of precise personalized resuscitation, which I showed you in Brussels in 2004. So that was 20 years ago. This slide is 20 years old. Using various input variables that are easily available, non-invasively, you ask the question, is your patient stable? If they are, have a nice day. If they're not, are they preload responsive? And in a positive pressure ventilation patient, it's a pulse pressure or stroke volume variation greater than 10%. And then you don't stop there. You say, are they hypotensive and have decreased vasomotor tone? The answer is yes or no. So half the patients that are in shock are not going to be volume responsive, but half will. So if I'm volume responsive, but I'm hypotensive with decreased vasomotor tone, yes, I should give you fluids. Yes, your cardiac output will go up, but your blood pressure won't. They need fluids plus norepinephrine simultaneously. Whereas if you're volume responsive and have normal vasomotor tone, that's like a hemorrhagic shock human. Just give them fluids, the blood pressure goes up. Finally, in the 50% of patients that are not volume responsive, are they have hypotensive and decreased vasomotor tone? Yes or no? If they do have vasoplegia, you know how to treat them. You give them norepinephrine. That's your septic shock patient. You've already fluid resuscitated. However, if they're sick, they're not volume responsive, they may be hypotensive, but you don't have decreased vasomotor tone, the problem is between my two hands. I don't know what it is, but it's right in my chest. And it's probably their tension pneumothorax or something like that. But we don't normally have to treat that. And then you recycle this every 15 minutes. So we created, through the U.S. Department of Defense, a completely closed-loop resuscitation system. The main tree from which this is on is right here. The paper is in press in critical care medicine, and it was supposed to come out this week, but I don't know if it has come out this week. The first author is Pinsky. And what we did is we had a decision, and we had as our target that I want to have a given mean arterial pressure, and we arbitrarily chose 65 because this was a controlled hemorrhage to a mean arterial pressure of 60. and a heart rate of less than 110 to mean that we didn't have increased sympathetic tone because we'd resuscitated. And we measured everything non-invasively. And our subroutines were to give fluids if you're volume responsive, but importantly, if you were only a little volume responsive, greater than 10%, you only got 5 mLs per kilogram. If you were more volume responsive, you got 8, and if you were really volume responsive, you got 10. And then we, at the same time, had a resuscitation and weaning of norepinephrine. We gave norepinephrine if your blood pressure was not high after the first bolus of fluid. And we weaned norepinephrine if your blood pressure was stable after 2 cycles of 15 minutes. We would then go down on the norepinephrine if your dynamic arterial elastance was greater than 1. We created from this a dashboard, which is, and for the Army is called Trauma Care in a Rucksack, which demonstrates the volume responsiveness, vasomotor tone, and cardiac power, and actually tells you in an open loop system what you should do. This you've never seen before. This is the first time I've shown this publicly. This is from our paper that's coming out in Critical Care Medicine. This is an example from one pig that was given controlled bleed, 5 mLs per kilogram until the mean arterial pressure fell, that's the third line down, to 30. We then waited, turned off the pump, then waited 30 minutes to represent the time it would take to get there, and then we started resuscitation. Being normal resuscitation, we first gave 250 of blood, which we got from the blood we'd taken out of them, and then gave them fluid, or on the top line you can see the norepinephrine, independent of each other based on the stability of the animal. And as you can see, the mean arterial pressure immediately came up to normal. The mixed venous oxygen saturation, which we were not using to drive resuscitation, normalized, and the heart rate remained high and the lactates fell. Those are the dots at the bottom. And furthermore, when we compared how well we were doing to a senior intensivist, and that was not me, it was Hernando Gomez, who was told, you were to resuscitate this animal, here's all the stuff you got, all you've got is the heart rate, cardiac output, stroke volume variation, and a mean arterial pressure, go for it, which is the only information that we use for our closed loop control. You can see that the time to stabilization by the physician was no better and no worse than the closed loop control. So at least we can say that on our own, without ever touching a patient, we're as good as a senior board certified critical care physician. So in the future, we are going to do pre-hospital effective targeted resuscitation. For sepsis, we're going to do point of care and do hyperinflammatory or non-hyperinflammatory to determine antibiotics or resuscitation. And we'll have selective en route use of these antibiotics. And for autonomous or semi-autonomous, precise, personalized resuscitation, we will be able to use minimally invasive monitoring and mechanical ventilation to effectively resuscitate patients and increase the golden hour to at least a golden 3 hours. And that's how I see the future. Thank you for your attention.
Thank you so much. It's okay if we ask the questions of the end? Okay?
No, I have to leave and give a...
Okay. The questions?
Are there any questions?
No.
Okay.
No. Stefano? Yeah. You have the questions?
That's all right.
No? It's okay? No change.
All right. Thank you. Okay. Sure.
Okay.
Maurizio.
Okay.
Thank you, Michael. Great talk, as usual. Since I will be at the end of the journey later, how the ICU looks like, how feasible is going to be, or what do we need to do to make it feasible, to really link to sensors and our watches and everything out there, so that what is not considered an healthcare device today can inform us so well about time zero of sepsis. If you think about the amount of resources that we're putting in A&E, thinking that that's time zero, but that's not really time zero, right?
Yes.
So how feasible it is, and when do you think this is going to count maybe to some pilot in some communities and so on?
Well, thank you for that question. The answer is that these pilots are already going on by Apple and other companies because they have large numbers of people which have the watches, and they've asked for permission to use those data just to see what's happening, and they retrospectively see who fell off a cliff or got sick or whatever happened, okay? We are also, with 2 other grants we have, are looking at non-invasive finger cuff and other things that sit on you and measure heart rate, O2 sat, etc. And what we are looking at is not the absolute values at all. We are looking at the dynamic trends and the interaction of the values using machine learning to define the features that are defining health or the lack of health. And we've discovered, to our surprise, that we can identify health very well. I can tell you who's stable. And of the others that I can't tell you, a majority of them are actually unstable, but I don't know. And so that allows us now in the next step in a 2-part to now say, I'm going to do more analysis of their features because I know they're the ones that aren't stable. And so that advantage is it can be done simultaneously, non-invasively, and you just have a ring on your finger and it's not because you're married. Okay? Thank you.
Another questions? No? Yes.
There's one.
This one.
Hi, Michael. Thank you for the great talk. Monty Python, University College London, and now Edwards Life Sciences. You compared the very experienced clinician to the closed loop. Have you added the closed loop to the very experienced physician, which would be more like fly-by-wire with the pilots, or you with your autopilot on your sailboat? I guess that would be the best.
Well, we haven't done that, but it is the next step we're going to do is actually put this in the ICU because there is nothing in this closed loop circuit that couldn't be open loop. Every single 15 minutes, it tells you, do this. And at the moment, it's closed loop, we just do it. But we could easily say every 15 minutes, go up in the norepinephrine, and the physician can elect to do it or not do it. And that would be easy to do, and it'll probably be easier for FDA approval. But that is a trial that'll be happening next year by people other than myself, who are the principal investigators on the grants, because I'm trying to step back from research and let other people lead our department, because I am getting old. And so those projects are going on. I'll still be part of them. But it's very, very easy to do an open loop system of a closed loop system as a clinical decision support because you've already got the information in front of you. Thank you for that question.
Okay, that's all. Thank you so much. Sorry.
Going back and forth.
No problem. It's the pleasure, the dead of mimic data set. It's a pleasure for me to introduce.
I apologize for getting lost.
No problem. Next presentation, I go in emergency room, and you can go. Thanks.
Thank you so much for the kind introduction and also for the invitation to the sponsors and leaders for both attending the meeting here in Brussels and for being part of the AI roundtable, which many of the speakers in this are. And Michael, you're a hard act to follow as always, and we're all getting old. I have to put on glasses so I can see the slide. So I was asked to talk about the future in the emergency department. And are we there yet? Well, I don't know where we're going, and I'm not really sure how we're going to get there. But I do know where we've been, and I do know that we don't want to go there again. So when we go to forecast the future in the emergency department, I think there's many things to consider, and we talked a lot about this the last 2.5 days in the roundtable. And is this truly the ideal future state where we have no patients and we're all out of an occupation and we need to find something else to do? And perhaps that's where we are headed. However, I think that as long as people are people and we do crazy things and we eat and drink inappropriately, we will always have patients. There's many domains that we need to investigate. But given the time, we really can just focus on one. And I chose to focus on the patient. Now, this is from our future paper in CCM that was looking at care in the future in the ICU, but I think it applies here. And you can see that at this very complex diagram, the center and the focus that we all have is on the patient. And I think the patient care goals are going to be the same. We need to triage and evaluate them. We're going to need to identify and treat them. And we're going to have to figure out where they are going to be dispositioned, whether somewhere else in the hospital or going home. And we have to do this in a timely and accurate manner. So what are we going to do for evaluation predictions? Well, I think triage in some level is still going to exist. We're going to have to identify where we think the patients initially will need to go. It may or may not be in the emergency department. There may be a different type of level of care that they need to go to, or they may need to go directly to the operating room. And previously, we had experienced emergency triage nurses who knew, looking at you, they didn't even need vital signs, this individual is sick, you need to go to a resuscitation room. This person, they can just get discharged from the waiting room. But unfortunately, our experienced triage nurses and our experienced clinicians have been leaving the field in droves, some due to age, some due to pandemic and burnout. But there's going to need to be some level of triage, and we know that when you augment triage with machine learning tools, it helps with the triage. As I said, we have more inexperienced individuals who are triaging these patients, and machine learning can help identify people that are increasingly ill that may not have been identified early on. And we know, as Michael has clearly demonstrated, that treating sepsis patients early saves lives and makes a difference. Now, for those of you who are Star Trek fans, Star Trek, the TV series came out 50 plus years ago, and I remember it, and McCoy was my favorite, Dr. Bones, as he was known, and he had that cool little device, that tricorder, and he could scan the patient and say, oh, what was wrong with you? And then for those of you who are Trek fans would remember Star Trek IV, they went back to 1986, and when they came back in time and he scanned someone, he says, what is wrong with you? And they said, I need kidney dialysis. And he says, my God, is this the dark ages? Well, here we are 40 years later, and we still have thousands of patients on dialysis. However, I think we currently have what our version of the modern tricorder in our hand. We have a computer with our iPhones and our smartphones and a handheld ultrasound. I mean, when we first got the first ultrasound in the emergency department, it was the size of a washing machine, at least the one that I had, or the old MA1 ventilators. And you can do really cool imaging with it now. You can image through the skull and see hematoma and blood in the brain. So there's going to be some type of scanning. Now, many trauma centers use the Lodox, which is pictured on the left, to make sure they don't miss any fractures or look for foreign bodies or potential weapons. I think there's going to be some kind of scan as we go through triage, whether you come in by whatever form of pre-hospital care there is or you come in on your own. But I think this scan is going to be non-radiation, so it's not going to potentially lead to cancer, and it's going to tell several things. It's going to look for acute problems, subacute problems, and potential problems, and it's all going to be real-time into your electronic medical record. And if it identifies a nodule in your lung that you don't know about, it's going to then set you up for a follow-up appointment when you're done in the emergency care. It's going to notify your primary care team, and it's going to let the ER team know that you have this potential problem so they can put it on your discharge paper, and it will also notify the patient. There's also going to be no direct contact of those leads and those annoying monitors where patients are tied to the bed. And how many times in acute resuscitation, especially if you're cutting off clothes, those leads get cut, they go flying, they never stick. I think there's going to be a different type of sensor. One of the things we see is with those routine leads, certainly in the emergency department and also in the ICU, our patients have those stickers all over them, right? And they're there, and that adhesive is there, and you try and clean it off, and their skin rips right off. So we're going to have some kind of new sensor that doesn't affect the integrity of the skin. For those of you who are in my cohort, you may remember those color forms where they would, these little toys that would stick to a storyboard, but you could peel them off and they left no residue. How cool was that? And I think that's where we need to go with patients. But looking at smart technology, we already have, many of us, smartphones, smartwatches. I don't have a smartwatch because I would probably break it. But we could use this technology, have it immediately on the patient, and then their vital signs and other information would get directly uploaded real time into the system. and be recorded, and the system would then alert us with change in trends or any concerning vital sign, would notify the care team. We talked a lot in our conference the last couple of days about video assistance. Everything will be videoed, and this is going to allow the care team to get away from the computer, not have to do documentation, because it's going to be able to video what is going on, identify what is happening, put that directly into the chart, document the physical exam, document the conversation that is going on, and give us a real-time record. And then the patient rooms, patients are not going to be lining the hallways anymore. You're not going to have to transport the patient to the death halls of radiology. My apologies to any radiologists in the room, but you know we have a lot of issues that occur in radiology and during transport. Everything will occur in the same area. There's going to be whatever the technology for scanning is, it will occur in the room. Everything will be available right there. We won't have to transport the patient. And then what about identification and treatment? Well, the team is going to be right at the bedside. They're not going to have to deal with the computer. The computer and the system, whatever it is, Big Brother type thing, is going to do the documentation for us. So that allows us to do what we trained to do, take care of the patient at the bedside. There will also be new therapies, which we have yet to envision, though Hollywood does sometimes give us a great example. This is from The Kingsman, and my apologies if I ruin the story for anybody, but it's been out for several years. Harry doesn't die in the first episode. In the second iteration, the other Kingsmen from the U.S. come in and they put this alpha gel into his brain. But just like now, they didn't get the alpha gel in there right at the time of injury. It was a delay, so he did still have some residual injury. So we're going to have to work on that. Virtual reality will also play a role, I think, in several ways. For the patients, those that are anxious or altered or having delirium, we can use some type of virtual reality that will then sync with their own memories and images to give them calming effects so that they can calm down. We will no longer need physical nor chemical restraint. And then for us as the clinicians and the physicians at the bedside, we will hopefully be able to look at the lesion or whatever the problem is. Will also be personalized. Now here, poor Bill, he has that nagging suspicion he doesn't really fit into his family. We need to be able to figure out everybody's own genotype and how they're going to respond to whatever the illness or injury is, and how we're going to give the appropriate immunotherapy and targeted therapy and care. We also will need rapid testing, much like what we developed during COVID, where we have 1-hour PCR tests to determine, do you have COVID-19, do you have the flu, do you have RSV, do you have something else that will help then guide treatment. And based on the patient's unique physiology and their response and what their anticipated trajectory is using machine learning and the clinical evaluation at the bedside will help determine where the patient is going to go. But we need to know the patient's background. Right now in the U.S., we have 3 main EHRs, and they don't talk to each other. So Care Everywhere works well if you are on an Epic system. But if you have Cerner or CPRS through the VA, you cannot talk to Epic. And of the 440 million Americans, 300 of us have an Epic chart. We're going to need worldwide access, so no matter where you are in the world, if you're in Brussels and God forbid you cross the street and just like I saw, some car blew the red light and drove right on through, takes you out. People need to know what your background is. It needs to be secure. It needs to be accessible. It needs to be up to date. It needs to be standardized. We all have to speak the same language. And this technology, we have worldwide access. Will it be cloud-based or something else? I don't know. But wherever you are in the world, if you have an illness or an injury, we need to be able to access your care. And then in disposition, we're able to predict outcomes. I mean, we all have good clinical assessment. However, sometimes patients fool you and they take a trajectory that you don't anticipate. Machine learning has helped augment outcome predictions and identifying patients that may have a bad outcome. And so we're going to use this technology to help decide, is your patient stable for discharge or are they going to need to go somewhere else? And if your patient is felt to be stable for discharge, services will be set up in the emergency department for follow-up with your primary care. Perhaps you need to go from the emergency department to physical therapy because you've had a fall where you haven't had a fracture, but you just need some conditioning, and you will go straight to a rehab facility with physical therapy. Or you will need some other type of therapy, such as home therapy, home nursing, medications that will be delivered potentially to your house by drone, maybe with Amazon or without. We'll see if Amazon still exists in the future. My guess is it will. But there will be some type of home sensor that individuals who've been treated in the emergency department and they're going home are going to continue going home with that sensor, so that information will be uploaded real time into their chart, and then alerts will go to the primary care or even back to the care team in the emergency department if there is a concerning trend. And for those that need to be admitted because they need care in the operating theater or they need further resuscitation in the ICU, those patients will then get transferred exactly how we do today. But I think hospitals of the future are going to look a little bit different. I think they're going to be acute resuscitation areas. It's going to be the emergency department where you receive your initial care, and then operating rooms and critical care areas, but then everything else is probably going to be maybe a little bit of observation to decide if a patient is going one way or the other, but then outpatient therapy, physical therapy, rehab, things like that. So what will the future look like? Well, I asked one of the AI models, this was Copilot through Microsoft. I said, what is the ER of the future going to look like? And they gave us really cool high-tech picture, as they do. Lots of monitors, lots of plants. I like that. I guess they're worried about our oxygen in the future. But there's no place for the patient. There's lots of, I couldn't see a stretcher. There's nothing in there. So I asked the question again. I said, where is the patient? Well, they took away that central section and they added a stretcher, but they still didn't put any humans. So perhaps AI knows something that we don't, and we are all going to be superfluous in the future. And I really hope that that's not the case. I think that wherever we're going, I think we in healthcare, especially in the intensive care and in the emergency department, we need to drive this and be the drivers of the bus and not the passengers on the bus, because we really do want to maintain the patient-clinician relationship. We talked a lot about that in the roundtable this weekend. And so are any of these predictions accurate? Well, I don't know if I'm going to be any better than the weatherman. I did like this one because they at least put question marks along the way, because they really have no idea with the weather. When I looked, it was supposed to be raining all week, and we have lovely sun here in Brussels. I recently had the opportunity to go to a beaches resort in Turks and Caicos, and everything was based on the coconut. So I think that's probably about as accurate as one can get with the weather. And for that, I thank you for your attention.
So I think we're going to power through just so we could catch up with time. The next speaker is a good friend, Azra. Oh, there she is. Thanks.
You're welcome.
Good afternoon. I hope everyone is awake at the cortisol dip. I'm going to talk about future of the operating room. Thank you for coming, and I hope you will enjoy this talk, although most of you here maybe are not surgeons. So I think that we are not far away from really living in the world where a surgical operating theater is a place where we seamlessly mixed virtual and real to really provide safer and more efficient care, and maybe come to the time when there will be zero error surgery. I have a caveat at the end. So let's start with the simulation training. I think simulation training, many of you are aware of big movements in the simulation training where you can use this really advanced immersive technology, immersive type of training that is not necessarily always in a physical space. In surgery, I think it's a particularly important. Here is example. Imagine that you have a trainee who has to perform a delicate brain tumor surgery by preserving healthy tissue around. And here he has a virtual operative assistant. Upon completion, the assistant provides him feedback instantaneously, offering really detailed insights into their performance. That is not only based on their actions, but also an insight in their psychomotor abilities. Like really, this is the way how you can offset or delegate what that apprenticeship model that we have in medicine using machine learning and computer vision. Then let's go a step further. Here is example of a video assisted thoracoscopic surgery training with augmented reality. Here you now move a little bit more in something that's resemble a Ready Player One movie, if you have seen it. On the left you have this device. On the right you can see now that the surgeon is training in augmented reality to do different motor tasks to practice before he even come to the surgical theater. So the AI will probably penetrate this market because as you expand complexity of the different immersive technology, you will need more of artificial intelligence to bring them to more smart levels. So the idea is that you will use, in a first stage, you can see here that you use 2D images to create 3D models. And these 3D models are printed in a VR. They are used to really provide, true representation, physical replica of the organs in a real time on which you can then practice. But then you move from the VR to more extended reality where you can superimpose in the operating theater this structure once you are ready and really have this kind of truly immersive training. One step further, let's talk about telesurgery and robot-assisted tech. Again, you have here AR, VR, enhanced surgery, robot-assisted surgery, and telesurgery. I want you to notice that as I move through this talk, you will see that how tightly connected are immersive technologies and AI, because that is the next frontier. I think, Apple Vision Pro just bring this to our attention so acutely. I think that everything we'll see in the future will be a combination between these two technology. So going back in the history, where we are right now, this is how we started, right? A long time ago, doctor had just few basic tools, relying a lot on local traditions to help patients. Today, operating theater, you have a surgeon who is almost even today in some wonderland with a lot of cool tools and anesthesia too, helping really the surgery be the safest possible and seamless. Now, today, for doctor in operating room, either is a surgeon or anesthesiologist, all these instruments, yes, they exist, but they are not always easy to use. We all understand, even in ICU, that often we don't fully can utilize the breadth and depth of knowledge or information we are getting from all these instruments. So how can technology help us really utilize them to gain what I call superpower? So the future of operating room might look something like that. You can see here you will have a decision support, context-aware augmented reality, cognitive robotics, needle navigation, perfusion monitoring. So here you will really see a lot of smart tools that are alongside a doctor analyzing all sorts of information to make surgeries go perfect. These futuristic operating rooms will know just exactly what you need and when you need it. So you can think about them like they're a superhero sidekicks, right? You being a superhero. These sidekicks really, the environment really becomes the tool, your partner in all of this. And it is beyond device, in my opinion. It's going to be completely context, so it's going to be embedded in environment. You probably will see Internet of Things with a lot of sensor. And I think this technology will move from the operating room because it's the easiest place to implement. It's the most controlled. When you master ability to do that in a controlled environment, you're going to move more towards most uncertain environment. And I think when you read a lot of new startup companies, you read very interesting statements like medicine is a science of trial and error, and we want to eliminate that. It's interesting, after I heard the talk about machine learning by trial and error, that a lot of people who are computer scientists think that we also operate by trial and error. So perhaps we can have a little bit different environment. AR, VR enhanced surgery. I showed you here how you progress from virtual reality to augmented reality to mixed reality. Here we can use in preoperative preparation, you can use VR because from the 2D images you can create 3D models that you can then use as example in cardiac surgery to operate on this 3D model of the heart and get really ready based on patient MRI and CT images. Once you are in operating room, you can go one further step. You can now you can think about that actually machine can analyze using computer vision tissue that you are operating on. And using that capacity, you can introduce tools that annotate images in real time, providing critical scene understanding, right? So you have this critical view that in yellow, where it can mark for surgeon areas of where they need to stay and to remain safe. I think this is even more enhanced by adding not only tracking the tissue area, but now you can track instruments and movements of the surgeons. And many of you perhaps have seen that a lot of these new tools now have attached ability to process image analysis and process tissue on the go. So you will be able not only to see everything and track yourself, but you will also be able to analyze at the beds, in that moment, tissue on a very low and a molecular tissue level. So I think this is fantastic. And I think this is one of the most exciting area for me. This is just an idea that you can observe surgeons' movements in triplets and then use machine learning model to predict a sequence of the movements and how well they are to following some perfect pathway. One step further, well, if you eliminate surgeons altogether, perhaps, for some operation, for some processes. Here's an idea of autonomous robots, smart autonomous robots, STAR, for a robotic laparoscopic surgery, assisting for certain actions, again, using combination machine learning and computer vision. Still research, but this is where field is trying to go. In this case, this is very interesting combination of the near infrared camera, again, sensors with learning algorithms that you adjust your movement based on a tissue movement. Like as the patient moves, the movement of the robot is attuned for the very delicate patient movement. This is the precision we are going for. And for me, this is like really transformative. 2021, we have first telesurgery, where the French surgeon performed surgery across the transatlantic in 21, with no delay in signaling processing. And here's another on 5G robotic telesurgery. This is also coming. I think this has a huge potential to really democratize access for a lot of people and expand the way where we actually practice and how we practice. But beyond that, what else is possible? Here's an idea that you can teach surgeons, giving them feedback using AI and computer vision. This is a study where they try to annotate the movement of the surgeon. And then you can see on the top graph that annotation of the computer vision scene was not even uniform among different sites, among humans. But then if you look between AI annotation and human annotation, there is still a lot of discrepancies. So we are not perfect yet. This is obviously technically difficult. But however, we can, using this kind of AI-generated model of explanation, eventually the idea is that you will be able to give fully real-time feedback on what is happening in the surgical field. And track not only surgical movements, but everything really. Scene, instruments, surgeons' movements, all of it. So I think we are coming like at a comprehensive, all multimodal, comprehensive surveillance of how we do surgery. I think this is going to open like a lot of kind of questions about, how do we now assess and measure competency, technical competency, and how transparent it will be moving forward. I think there is a lot of gray area, and I'm just interested to see what future may bring. So that's all I have.
Oh,
thank you.
Thank you, Azra.
If you want a question.
Very nice presentation, as usual.
Thank you.
And now, questions.
Yeah, we could bring back maybe
Bye, Prof.
Yes.
See you. Bye.
Heatherlee could come up as well if there are any questions from the audience. Yes.
Okay.
Azra, fantastic work, and despite 3 days together, I still have questions. So
more questions.
yeah, more questions. You're doing some great work on this technology. How easy do you think it could be to deploy some of this to the other side of the world, to other hospital systems? How easy is to do this, and or how difficult it is to calibrate it to local surgeons, local practices, different populations, and so on?
Just for the full disclosure, these are not my studies. These are studies across the world. I think, these are probably now located on some very specialized center. I know, in my opinion, VR, AR is very close to be deployed in a medical education. I don't know. We already use quite a lot of simulation. In emergency room, we have a huge simulation. I have to tell you, next building we are building is a simulation building. Okay. I think that the medical education will move towards that immersive training in virtual environment or on a digital twin environment, because it really makes sense from many standpoints. But I do think that immersion matters, that it's not the same if you are in some kind of not really embedded in a really immersive environment. For me, working in ICU, working in an emergency room or operating room is like being in a combat in the battlefield. You need to be embedded in that to feel that pressure, that psychological pressure. Another thing that I think is really important, that we will be for the first time able to measure the cognitive load in humans. And you saw these papers about decision making, just put a Magic Leap goggles or put an Oculus and look what happens. Because as of now, I can tell you that the entire research is on collecting from VR players, their ocular movements and understanding where you look, what's your stress, and what's your next move. And I think we will be using that probably maybe in a medical field.
I completely agree that it's good to have our trainees know the procedure, understand the procedure, so that they don't have that stress and they're not practicing on patients how we all did. But I do think that you don't get that real feeling. You have to be embedded. You have to have a live patient in front of you, where if you make a mistake, you could cause harm. So I do think that simulation is wonderful, and I think we should expand on that. But until they're at the bedside, we still need bedside care, and that's where we still need trainees to take care of patients with us.
Agree, but we don't need to do that. See one, do one,
kill one.
You don't need to do that, or because we a little bit more than do one. Let's really do a lot. Let's do from different angles. Let's make scenarios, and then get that competence and confidence. And I expect that once they can measure us, you're going to have to do that. Once you measure, you will know.
Well, and I think the same thing, that we're all going to have some type of sensor so that they can sense if we're getting overtired and we're not making clear decisions or accurate or rapid decisions. If we're very stressed about something, that a colleague could, take over, or you could have a 2-minute break, which we never get. Exactly. And we usually just power through. And so I think that's also from the clinician standpoint, we will be monitored as well.
Yeah. Another questions? Yeah.
Hi, Kate Heisey from Mayo Clinic. I was thinking about putting all of this together, right? The pre-hospital, the more efficient emergency department, straight to the OR kind of concepts. When you guys are looking at these things, how feasible, in what time frame are you talking about? And when we consider this, the visualization of the future, what can we feasibly see in, say, 5 years?
So I think a lot of the technology is there, right? There's technology that takes and can transcribe video into text. That exists. We have EHRs. The problem is that we need to have a system where they all can talk to each other, that we use the same language. There are sensors that people go home with. People go home with pulse ox, and they have cardiac monitors, they have the Zio patch, they have all different kinds of things that we can monitor from home. It's just not being done necessarily real time. It's a call in, or they have to send the patch back, or whatever it is. So I think a lot of this in the next few years we will see, but then coordinating a worldwide effort with a universal EHR, I don't know that that's going to occur in our lifetime, at least in our academic lifetime.
Another question?
Hello, Azra?
No, sorry.
I agree with you. I think it's going to depend from around the world, and again, these are expensive tools. For me, I think that, as I said, VR, AR, I think for medical education will be the easiest one. Probably in Western countries, developed countries, probably is already there. in medical education at least. Operating room, a lot of robotic is already there. I think operating room might have more incentives, at least in the United States. It matters and it makes money, so there is incentive, and there is ever more pressure really on surgeons to perform. There is no doubt about that. So
I have a quick and not easy questions for Azra and Heather. For Azra, what do you think about the use of wearable devices in a general ward after admission of operating room or surgical operating room and the day after surgery? And for Heather, the use of telemedicine in emergency department for the other specialists?
yeah, that's an interesting question, about wearables. Do you mean on patients or on the providers?
Patient.
Or both?
Yeah, both.
Yeah.
I don't know, perhaps on everyone, right? I think that, we already monitor a lot of things in hospital. Well, depends where you are in hospital, but you hope in operating room we do. I do still think that, there are certain things that are easier to monitor with wearables than they are with the machines in operating room. So I can see that, we have explosion of the sensors now, at least in a, development stage that not measure only physiologic signals, but now measure tissue level signals, or ultrasound or imaging, and I think that will also enter the market. That's probably a little bit more far away, but maybe wearables for doctors, who knows?
Why not?
So as for telemedicine, that, as we all know, exploded because of pandemic, and we've been using telemedicine for several years now. We had been using it before, but from the emergency standpoint, we do it for two reasons, at least in my emergency department. One was at the beginning of pandemic, we wanted to keep anybody and everybody who didn't need to come to the emergency department out of the emergency department, so it would not increase our burden. And many of the people don't need to come to the emergency department, and so we would assess them, and we, by video or by phone, have a conversation with them, and we could prescribe medication either through the VA system or through their local primary pharmacy, because the government had created a policy that you could then call their local pharmacy. It could be done both electronically and by phone to take care of this. And I'll tell you that first 2 months of pandemic, when everybody else was trapped at home, I cared for more poison ivy by video because everyone was out weeding their garden that they hadn't done in years, and so everybody got there was a lot of poison ivy that I had to treat by video. But I think it's here to stay, and now we use it also to help provide additional care. We also do it for follow-up. Patients who've been to the emergency department, we can then set up a follow-up appointment by video, and we have a thing called the ICT Scouts, where our combat medics can go to the patient's house, and if they don't have video access and they don't have Wi-Fi, which in many of the areas around where I am, once you get away from downtown Durham, the Wi-Fi is limited, they will take a device to the patient, so that way you can connect with that patient and then give them care, make sure their follow-up is appropriate. So we are expanding it, and I think that's just going to continue to expand.
Thank you. Question?
I'm going to ask a harder question, and it's really a follow-up to Mauricio's question. So what is the future of medicine for those who cannot afford it? Because even us who come from rich countries, we see such a wide divide. And what are our obligations to make sure that the technology that we're producing is truly benefiting everyone?
You were president of SCCM, not me.
Well, from the human point of view and from a physician point of view, I think everyone should have access to health care. Several presidents ago in the United States, a president stated, we have universal health care. It's called the emergency department. So anyone who needs care can come to me. And that's true. We have an obligation to care and evaluate patients who come in to make sure that they are stable and treat them. The challenge is what do you do once you're done in the emergency department if they don't need to be admitted? And it's a challenge bigger than I'm able to answer, but I do think on the worldwide level, we need to ensure that we have a healthy population across the globe. Because if we don't have a healthy population and people who are continuing to get ill for reasons that they don't need to, making sure they get the appropriate antibiotics, making sure they get the appropriate care, it only makes us weaker. And I think as a humankind, we really need to make sure that everybody receives appropriate care. How we go about that, we haven't been able to answer yet. I don't know that I have a great answer for that, but I think we do need to, between governments and societies and individuals, work towards that goal.
I think it's a really important question. I think it's a kind of bi-directional. On one hand, I think there is no doubt that the divide will be larger. There is no doubt about that. The things that are coming are truly, transformational, not just like on a society, but it's biologically transformational. We are looking at technologies that can enhance humans eventually, 5 to 10 years from now. And they will not be available to everyone. But then on the other hand, some of this technology can allow also access democratization. If you build an operating room like this and you put it in a metaverse, like a digital twin, and everyone in the world would be able actually to be in that operating room and watch that operation. Like you can open training across the world. You can also, if you think that this telesurgery works, you can have one robot somewhere where there is no surgeon and surgeon somewhere else can operate, right? Like there is that option, especially in times of the crisis or war. I think that's a good and bad, like everything else. There is a good and bad. I sometimes think if you have a zero-error surgery, there will be something else. There is always that's a human life. There is no zero error, zero danger. That's life, and I think we have to accept and wait for the next thing.
Well, and so many places, they may not have a lot of technology and a lot of funding, but almost so many people have a smartphone, right? So that you can access through care and have conversations and video visits. And at some point, I imagine that we will have drones that can travel long distances that could deliver equipment or medication. I mean, drones are already delivering AEDs to cardiac arrest patients in different areas of the world. Drones are assisting in drowning victims to fly life preservers out when you can't get close enough to them. So I do think that even in areas of limited resources, that there will be options, most likely through our brain in the pocket.
Thank you.
Perfect.
Good.
I think we're right on time for the next session. Thank you very much.
Thank you so much. Really, thank you. Okay. And it's a pleasure.
Italian would introduce an Italian.
in English. And so it's a pleasure for me to present Maurizio Cecconi, Mr. President, always, the future of ICU.
Elena, Leo, hello everyone. So we are finally going to the ICU, but I also like to start from outside of the ICU, because when we imagine the future of our ICUs, we have to realize that we have a crisis now in the world about what healthcare is and what health is. And I think really it's the time to embrace new technology, to embrace new disruptive ways of thinking about healthcare. I like to look at numbers in a very simple way. This is before COVID, so this is from Eurostat, and it was just projecting the change in the age parameter in the European population. So there is already inverted, with a lot of very old people after the age of 65 there. It is going to get worse in the next 30 years, so there will be many more patients, many more citizens that are old, and especially for women. Why is this a problem? This is a problem on two folds. Everyone always understands this linear relationship of sicker patients, more patients coming to the hospital. It's actually going to accelerate if you think about standard models of care and from an healthcare worker perspective, because having a lower proportion of young citizens means also that we're going to have a lower proportion of healthcare workers that can look after patients or citizens that are becoming patients. So basically, we are shrinking in proportion to the care that actually is exponentially rising. So just to believe that opening new jobs, increasing budgets for new jobs that we cannot fill, because many people don't know, but actually we may have in some units, in many units, less ICU beds open now than before the pandemic. Even if everyone is thinking that we are better prepared and better ready now, well, now we think about it, but actually we have the funding, we don't find the people to fill those jobs. And coming back to what Leo was saying, one of our co-chairs, I know this is something close to his heart, I also think that we have to embrace this revolution and drive technology in a way that probably, Leo, I suspect it will increase divide of what's available at the beginning. That's a bad thing, but that's the story of technology in human history. As long as you're driving improvement in other areas, probably this is something that we can accept, as long as we have a sense of equity and a sense of being inclusive and a sense of bringing, I think, technology and bringing them with us. Certainly, we didn't do this with the latest technology that we developed in record time during the pandemic. RNA vaccines, super fast, thanks to 20, 30 years of research before. Have we been good at deploying them in low and middle income countries? I don't think so. This is the map in the middle of the vaccination campaign in the world in 2021. It was selfish. It was also a bit stupid because then variants circulated and then came back even to richer countries. So I know that this is not vaccination. We're talking about a different technology, but I think that we need to learn from these things. Nevertheless, I think every time we have a major crisis like the pandemic, and pandemics in the past, it's a moment also where humans get together, societies get together, and they realize that actually caring as we've always done, or solving problems as we've always done, is not going to work. And I think similar to how intensive care was born after the polio epidemic in 1954, thanks to simple ideas really, and to replace the old model of respiratory support, I do believe that now we are in this moment in history where we have several crises knocking on our doors, from the aging population, climate changes, really sustainability and so on, that we have to think how our intensive cares are going to look into the future. And so we've learned from the pandemic. Now is the time to move away from the pandemic and to see how we're going to get ready for next and future threats. And some changes were already occurring well before we noticed that COVID was hitting a few years ago. So hospitals are probably shrinking compared to what they were in the past, but the proportion of what is an acute bed is actually increasing everywhere you work. Now, what is an intensive care bed? Very difficult to define. I worked in different countries. I have the privilege to know many colleagues from around the world, to do rounds and go and visit different hospitals, different healthcare systems. I can tell you that pretty much where you have the resources, a level 3 patient that is intubated and ventilated will be in what you call an intensive care bed. A level 2 patient that requires extended monitoring, maybe an norepinephrine drip or a vasopressor drip. In some places it will be in an intensive care unit. Our colleagues in the US have usually more beds than us. In my hospital we don't have that, and I'm not working in a poor area, but we just don't have enough level 3 beds to fill them with level 2 patients. So what we have done, we have extended in a number of wards monitors. We have early warning scores. We go and review these patients. We try to bring some of this care there. Of course, we're trying to centralize everything that requires organ support. So it's a very dynamic situation, and it's going to be this change driven by demand, not by the offer. We have the illusion to think that we design where and how to provide intensive care. The reality, if the demand is there, maybe it will be patient-centered, maybe it will be family and experience-centered, maybe families that will tell us, I'm not happy to change a bed or a ward just because my disease is changing a bit, and last week it was the heart of my father, but next week maybe the lungs are going to be a bit worse, and you just change around. So these concepts about being flexible in the acuity that we can care for are going to be very crucial. Of course, again, the biggest limiting factor here is not going to be technology. We can monitor everywhere. That is just having enough money and to be able to deploy this IT and this monitoring system. Is how do you respond with the right skills to patients that then deteriorate? We cannot dilute this too much, clearly, sending everyone and treating every patient with ECMO in a normal ward, but probably we need to think about reskilling, upskilling, different ways really to interconnect all the vital signs in our hospitals and bring intensive care where intensive care is needed, not just inside the four walls of the intensive care. If you can afford it and if you have the luxury of going for new buildings and new ideas, I also think that the intensive care of the future will really try to focus also on patient experience and family experience. 20, 30 years ago, we were seeing a lot of intensive cares being built in the basement. They were always telling us, your patient is asleep anyway, so you don't need the daylight. Well, We know that that's rubbish now. Actually, there's a lot of data about the daylight importance and the circadian rhythm. And it was also forgetting that we need healthcare workers there in one of the most stressful and more intense areas of the hospital from a work point of view that probably we should take care a bit better. Interestingly, technology is really becoming very smart. Even if you cannot build a new hospital, you can still use technology to bring this humanization and this feeling of being connected maybe to the outside world. This is a picture from the neonatal intensive care unit of the Mangiagalli Hospital in Milan. I was actually a parent for one of my kids there. And what is very interesting, you see that there is this ceiling here, and there is a very nice sky that you can see from these windows here. The only problem is that above this ceiling there are probably another 4 floors. So there is no window and there is no sky there. It's a very clever technology that you install on the ceiling, and it mimics, with a very clever combination of sand, water, and lights, the daylight. And when you are there, you have the feeling that you are looking at the sky outside. It completely changes your mood. And we are, for instance, we have one of these installations in one of the gamma knife areas for our hospitals where patients come very stressed. We give them the feeling that there is something. I know we are probably cheating a little bit, but in that moment, it's still something that is calming you down and is bringing you to a better mood. The ICU of the future can only exist if it works in the hospital of the future. So we need to be able to bring intensive care outside of intensive care where it's needed. This is going to happen only if everything is going to be interconnected. And interconnected means also interoperability. We've been asking this to medical devices companies for a number of years. Finally, I think everyone is realizing that we cannot be so close. We need to have open protocols, and we need to think about building infrastructures of data that will be queryable. I was chairing with Azra the roundtable for the last 3 days, and this was certainly one of the most important aspects that we said. We really need to bring this interoperability and to bring these infrastructures of data that we should be able to query in real time. If you speak with people outside the hospital setting, maybe your friends or families, they will think that we can just probably put a query there and maybe find out what's happening in one patient or the other. The reality is we are far away from that. We are digitalizing a lot of things now, but actually to have an infrastructure that is completely interconnected, that you can really interrogate and can give you details in real time. And real time maybe doesn't have to be now. It could be everything that happened in the last hour of the hospital. This is something very important if we really want to be able to detect trajectories and to be very cost effective also on how we deploy resources. Because a system like this, again, is going to work if it maximizes our resources, which means I don't want false alarms ringing every 5 seconds. Some people say it's better to have one false alarm, one false positive alarm more than one less. Yeah, maybe one is okay, but it's not good to have 100 false positive alarms. That brings fatigue, that brings disengagement from the nurses, from the doctors. At some point, no one is looking at that alarm. So really very important that we always keep this human-centered approach, patients, families, but also the healthcare workers in the loop. And in this sense, I think real quality improvement, we were joking a lot about quality improvement in the last few days, and somebody will say we shouldn't talk about quality improvement because it's just masking research. I mean, if that's the case, I agree, we shouldn't call bad research quality improvement. But real quality improvement, which means seeing what's happening in your intensive care unit all the time, can be very valuable. For me, just a very simple dashboard that I was able to receive and to display weekly about the hand washing of my team and the external team was allowing me to increase hand washing from 40% to 95%. It's not rocket science, but it's just bringing data that you can visually utilize there. And maybe these are some of the low-hanging fruits before we start to think about completely closed loops AI systems. So, and talking about symptoms, again, I was president of the European Society of Intensive Care during the pandemic, so we knew the stress of our teams during the time. We even studied the stress, and we found really that up to 50% of our teams members that were experiencing some symptoms of burnout. So it's not surprised that many have left the profession, and I think now we need to sit down, we need to say, okay, maybe we have done some mistakes there. Maybe we have not been as good as we should have been in protecting, especially our nurses. Many have left the profession, they changed. We have this identity crisis now where we have less people taking care of sick patients and less people that want to go and become doctors or nurses. Less people that want to go and work in emergency medicine, in critical care. How do we lobby with the policymakers so that we create jobs that are attractive? We shouldn't fight the new generations. We should accept they have different values from the older generations. And how do we bring those values so that it will become, again, an attractive place working in intensive care? Because we will need human resources. They are going to be, for sure, the most important and scarce resource for the next 10, 15 years. Maybe at some point we will have robots that will have verifying movements and they will be able to take a lot of the task, manual tasks that maybe a nurse or a doctor can do. Something like this, I think it's probably years ahead or maybe decades away. But maybe some facilitators that can actually start to help rolling and moving or taking away bureaucratic time for refilling cabinets. So we start already to see robots that are bringing drugs from the pharmacy, bringing the trolley. And all of these things, if they increase the value time that an healthcare worker can bring at the bedside, I think is something that is very, very valuable. And I also think, and we were discussing today in the last 3 days about this, we need to teach a new generation and new skills in the new generation of healthcare workers. This is an example from my institution. I started with the Technical University of Milan 6 years ago, a new medical engineering program. It means that these will be physicians and biomedical engineers at the same time after 6 years. It's not that they do one and the other. We're actually bringing engineers and physicians teaching on the same course. And I can tell you, the first cohort is graduating next year. It's really fascinating to see how they're coming to ask their final dissertation and the skills that they've developed. But what I'm very proud at the moment, actually, they are scoring very high on the OSCE for empathy and for how they interact with patients, because we put that part of the curriculum as strong as the one on data science and signal processing and so on. And again, this is very important. They don't want to go and become data scientists. I was very surprised about this. I thought when we start this, I thought maybe this will be for 50% of them a fast pathway to the healthcare industry. There's nothing wrong in that. But actually, no, they want to be doctors just with a different set of skills. And we need to bring really this set of skills so that we have, I think, this technological revolution, but at the same time, we tackle this identity crisis of our profession by keeping this sense of this connection between souls and this humanization of care, which I think is what really brings value when you go back home in the night. How do we do that? I was discussing about this morning during the opening. I really don't think we should embrace and go straight for closed loops and AI. Systems are not ready, and probably culturally we are not ready. But augmentation, I think it is there. We've already seen some example of this. I think we just have to be a little bit more brave and probably start to use some of this for how we deliver intensive care. And particularly in intensive care, I think one of the revolutions that I'm really looking forward to is what I refer sometimes to when big data meets big trials. We know all the problems with big trials in intensive care. We have an idea on a specific group of patients, but we know that it's going to take years to find that group of patients. So then we really make very loose inclusion criteria, and surprise, surprise, the study 9 out of 10 times is negative. So what about identifying phenotypes and randomizing, again, just in those phenotypes there? In order to achieve that, we need really to get together in very large networks of intensive care, though, and then using this to identify phenotypes, maybe in real time, and to randomize to interventions that actually are suitable for that patient. So I really enjoyed very much today the papers that were released in JAMA, the one, if you were at the opening, this idea that you can actually train an algorithm on one randomized controlled trial, identify a phenotype, and then see if it works on another one. We then have to see if it works in real life, but I think this is a clever way to accept that we still need to randomize, but we can use observational data to become more precise. And to conclude, so I think we have major challenges ahead, but I don't want to scare you, because every time we had major challenges in history and technology came, actually we got better. And today, I'm also worried about social divides. But if I look back in history, every time there has been a technological revolution, this has usually brought an increase in the quality standards. And probably many of us live with better quality and hygienic standards at home than some kings in the 14th or 15th century. So I think we have to be optimistic about this revolution, try to bring this revolution forward. And I'm just going to conclude with maybe my dream for the future. Jean-Louis Vincent asked me last year, can you write a piece on how you think intensive care is going to go? And I was thinking, how would I do it? And I thought, let me just imagine that I'm about to retire now in 2050. I'm in Italy, probably this is going to be 2090 because we're not going to get any pensions there. But, and I was thinking, how would I look back? And how would have been these changes in the last 20, 30 years? And what I hope really is that we would have embraced this revolution. We will have a lot of more data, maybe very large monitors. Maybe we'll have avatars or infectious disease specialties. Somebody criticized me for this. He told me, but don't you think it's better to have a real doctor? And I said, of course I think it's better to have a real doctor. But don't you think it's better to have an avatar than nothing? Because sometimes you ask the referral and actually no one comes maybe for the next 2-3 days. So I think we will have some of this. But my plea really and my hope is we will be able to have a lot of decision making that it's easier for us, that we will be able to focus on the clinical decision making, probably writing a bit less notes, spending less time in front of the computer, and more time with the patients and with the families to really to bring this connection back. Thank you.
Let's leave the Inquisition at the end of the three speakers, just so we will have enough time. Thanks, Maurizio. The next speaker is a clinician scientist from Imperial College in London, Dr. Matthieu Komorowski.
All right, I'm just waiting for, yes, here we go. Thanks, Leo, thanks, Elena. So, Maurizio, you offered a very good transition to my talk because you said we're not ready for closed-loop AI and fully automated AI, and that's exactly what I'm going to show you in this particular application of machine learning systems to inform sepsis resuscitation. These are my conflicts of interest. Some of what I'm going to discuss, we presented some of that in the last 3 days during the roundtable. So some credit goes to all my very dear colleagues here. All right, so sepsis resuscitation. In my opinion, probably one of the hardest questions in intensive care. We really don't know what's going on, right? We have this mental model that there's somewhere where tissue perfusion is optimal, and that depends on the amount of fluid and the amount of vasopressors we give to patients. But that's pretty much all we know, right? So many unanswered questions. What is volemia? How do we measure it? How much fluid do we need to give initially? And then afterwards, when do we need to start removing fluids? When do we start vasopressors? What is a good resuscitation target? Right? So there's a lot more uncertainty than knowledge. And really, then, in my opinion, the question comes to, because we failed for so long with everything else, and we collect so much data, and we have this very exciting methodological methods that have appeared, that have been created over the years of machine learning and AI. Could data-driven approaches help? And this was really actually the reason behind me moving to the UK to get education in machine learning after I finished my specialist training in France. This paradigm kind of allows us to move from predictive AI to actionable AI. Predictive AI is simply trying to predict events in the near future. You know, is my patient about to develop sepsis, yes or no? And then actionable AI, it takes it one step further. Could an algorithm inform me about what the most optimal decision is at a given time for a given patient? And it's very, very, very promising. There are computational frameworks to try to actually implement this with data. So in September 21, we conducted a scoping review on this question. Then we updated it 2 years later, on the question of machine learning approaches for individualized cardiovascular resuscitation of adult patients with sepsis. Obviously, we had very specific inclusion and exclusion criteria. I'm not going to dive into these. That's the inclusion flow chart. We found 73 papers, and I'm going to try to give you an overview of what we found. So most of these, all these papers obviously belong to machine learning. There's 3 big pillars in machine learning. Here, for the sake of this presentation, I added biological modeling on the right, but I assume you know by now what's supervised learning, what's unsupervised learning, and what's reinforcement learning. And here, with the added category of physiological models augmented with machine learning as a 4th category. So the papers distributed this way, most of them were in supervised learning, followed by RL, and then we found only a few in clustering, and then the physiological models at the end. The timeline is this one, as expected, right? I don't think there's any surprise here with a boom over the last few years. So I'm going to show you a few examples in supervised learning. This is the typical paper we found and we included in this review. So this is the InSight system, which is a sepsis prediction model based only on vital signs, 6 vital signs. What you see here is the figure to the right is the AUC for the prediction of septic shock, which is basically defined as the initiation of noradrenaline in this population 4 hours before the initiation of NORAD. This model can predict that label with an AUC of 0.96. So if we take a little shortcut here, what would we do with that information? I'm not saying that that it will be straightforward to translate this, because what would you do? Would you start NORAD earlier because you know that your patient is about to be started on vasopressors? And if we did, is there evidence that this would improve outcomes? Not sure at all, right? But maybe this could at least potentially inform our clinical practice. That's another. This is the only randomized trial we found in supervised learning where a model was trained to wean NORAD rather than start NORAD, and they found that when using the system in a randomized trial, the NORAD was weaned faster than when it was left to humans. And then we found a lot of oddities, or like this one, the prediction of blood pressure depending on how much NORAD you get, prediction of how much NORAD you need to achieve a blood pressure. The one on the right, bottom right, is the prediction of urine output after fluid administration. So all of these belong to the area of supervised learning, right? You try to predict some label or some quantity based on input features. Unsupervised learning, so this is the area of clustering in particular. I'm just going to focus on one paper, but I think it's a really interesting one. Zhongeng Zhang in China. So they have a cohort. They use this cohort of nearly 1,500 patients from 25 different ICUs. They all have septic shock. The paper starts with a straightforward clustering. So they split those patients into 5 groups. They have time series of data. That's important to keep in mind. So they have data during 7 days after sepsis onset. The clustering led to these 5 groups that you see here. On the right, it's a picture showing the principal component analysis of the 5 clusters. They define, for example, the class 2 is the one with the highest degree of organ failure, the highest rate of mortality. Class 3 is renal dysfunction. And then they built a dynamic treatment regimen model, which is basically some kind of causal inference, but that allows you to take into account continuous confounding and continuous treatment. So it's very, very appealing for the kind of questions we deal with, right? These are sequential questions, and there's heavy confounding. Giving NORAD, you know what I mean. Obviously, NORAD is associated with high mortality, but that's because those patients are sicker. So anyway, what you see here on the screen, the top two plots are related to fluids. The bottom two are related to NORAD. On the right, they show that so their model suggests an optimal dose of fluids and vasopressors. They show on the right that when the AI and the doctors did the same thing, the patient's mortality is the lowest. So that's an indication that the model is saying something useful. And then on the right, you see the fluids and the vasopressors given to patients. I think that's in blue, and the optimal one in red, suggested by the AI. So an interesting model that could provide some kind of personalization, and there's some interesting features here. For example, if you look at the group 2, which is the sickest one, the AI would have given more fluids more aggressively initially on day 0. And for example, in group 3 here, the AI would have given more pressors to more patients. And remember that that's the category of patients with renal failure. So, maybe some clinical plausibility in some of those results. Reinforcement learning is my particular area of interest. Here, what we do, we model a sequential decision problem, and then you attempt to optimize this decision process to maximize a reward. This was my initial PhD work, where we trained a model to do the same thing, to optimize fluids and vasopressors in patients with sepsis and septic shock. This initial model was based on a discrete Markov decision process that had 750 states, and the action space was 25. So you had 5 increasing doses of fluids, 5 increasing doses of NORAD, and basically any combination thereof. So this is a couple of years ago, and since then there's been a lot of development in this area, particularly when trying to improve the state definition, trying to improve the interpretability of these models, because they're really, really black box. We have no idea why the AI says to give 99 mils of fluid over the next hour. So here's an example of a more recent paper where basically the state space was shrunk to only 19 states, and that allows you to very finely explore what are these states made of, what are the characteristics of patients in all of these states. So bringing some degree of explainability. Finally, biological modeling. This was very, very scarce. The only paper that's maybe worth mentioning was the early flow track assessment studies. I included this because there is some machine learning involved. It uses routinely collected data. There's an integration of the area under the curve of the art line plus demographics. So it sort of ticks the boxes for inclusion. All right, the state of deployment. This is the interesting part. Just like every other area of AI in intensive care, the state of deployment is limited to usually internal validation, meaning all the papers that we found and the literature in this area they were not tested prospectively, they were not converted into a medical device, they were not integrated into the workflow, or very, very scarcely. And the reason for this is relatively obvious once you start thinking about what the process involves. So when you want to develop and deploy those tools, you need to have data. Well, that's these days much more easy. Developing the models is very straightforward, but deploying them is very complicated because you end up hitting hurdles, and some of which are way beyond the expertise of a clinician or of an academic. And I'm just going to list some of these, but obviously there's going to be some human factor studies involved. There's a lot of technical issues. I spent 1 year connecting an AI that we developed at Imperial, connecting this to UCL Hospital, so just down the road in London, but just because they use 2 different IT systems. So interoperability is a huge challenge. I read a survey saying that the average hospital in the US uses 16 different electronic health record softwares or solutions, 16 on average per hospital. information governance, patient trust, algorithmic fairness. All of these are important aspects to consider. And then there's the whole can of worms of medical device development. How do you go about doing this once you have your model that's validated and you think it works as a research project? How do you convert this into something that's regulated? How do you conduct health economics analysis and so on? As part of the research we conducted, we made a list of a few recommendations. So one of them being multidisciplinary collaboration. This is something that Leo has been pushing for many years now. This idea that you need to bring people from different fields in order to achieve anything, and that's very, very true in this particular example. This is a picture of the team I work with at Imperial. So Tony Gordon is the boss, and then you see that it's highly, highly multidisciplinary. We have machine learning people, software developers. We work with the hospital informatics team, human factors, health economics, PPIE, clinical trials, medical device development, and our study manager Liz. So and it's still not enough. I wish we had more people. And then we made more recommendations. Some of them are really obvious. You need to design the system around the clinical workflow, rather than building your model, chasing the AUC, and then, what do I do with this? External validation, clinical trials. We talked about this a bit. Collect patient-centric outcomes, and equally important, once the system is deployed, you need to have. So this is an FDA and also an MHRA requirement to have processes in place to do post-deployment surveillance. You need to be able to detect whether the performance of your system deteriorates over time, when you need to retrain your model, and so on. So to conclude, ML for sepsis resuscitation, yes, I want to say yes, maybe one day, and I want to believe it's going to work because we have nothing else, but not just yet. Thank you.
We'll save the questions for later.
Oh, if you want.
Just so we could keep it on time.
Ah, okay.
You want to introduce Michelle?
I have
my chocolate.
My chocolate. Next speaker, dear Michelle, and the organ failure, yes, and but the future. Here we go. Thanks.
All right. So, good afternoon. It's getting towards the end of the day. So, I've been assigned to talk about how I see the future, monitoring organ failure hospital-wide. So I have some conflict of interest, including grant funding on a variety of things and chairing some DSMB and scientific advisory panels. So let's think about what we think about in terms of the ICU and organ failure. So we traditionally think about organ failure as something that we manage in the ICU. But I would say actually that this paradigm is changing for a number of different reasons, some of which actually Maurizio was talking about with the aging of our patient population in the hospital. So when you look at all patients in a hospital, you realize actually organ failure is not confined to the ICU. So this is a study where we looked at organ failure by SOFA score calculated every 2 hours on all patients in the hospital starting from when they were admitted. And you can see actually a large number of patients, 24% of hospitalized patients, are present to the hospital with a SOFA score greater than 2. And this resonates if you look in the emergency department, where actually the amount of time spent critical care delivery has more than tripled over a 10-year period, even as the number of beds has stayed stable. But this is actually just the tip of the iceberg. When you follow these patients over time while they're in the hospital, you see actually there are a lot more patients. Almost 45% of the patients in the hospital will have a SOFA score greater than or equal to 2. In fact, another 20% of patients who didn't have an elevated organ failure score in the beginning ends up increasing their score sometime during the hospitalization. And the organ failure is not the same. So if you look at actually what people present with in terms of organ failure, the most common is actually renal failure. Now, some of that may be chronic, and such, because we don't always know every creatinine on patients before the hospitalization. But if you look at actually rise, or what we call the hospital onset of organ failure, defined as a change of greater than 3 in any one specific organ system, you find actually the bulk of the organ failure in the hospital is hospital onset organ failure. And the most common is actually respiratory failure, followed by cardiovascular failure. Now, respiratory failure is the most common reason and most consistent reason for admission into the ICU. But when you look at where the patient was when they started increasing their respiratory SOFA score, it turns out the bulk of the patients started worsening before ICU admission on the floor. Now, that may be okay if we know it and we brought them to the ICU right away, but I don't think that that's what's happening. This is a study where we looked at actually patients in which critical care was called to evaluate for an ICU. So that's those patients in red. And then there are patients actually who admitted around the same time in which critical care was never called. And if this is actually when critical care is called, and you look back on their SOFA score in the 12 to 24 hours before we were called, to 24 to 48 hours before, and then 72 hours before, you see actually patients who need critical care, higher SOFA score, not surprising. But you also see actually there's a worsening of organ failure, and this worsening starts actually as early as 48 hours before critical care is called. This delay results in adverse events. There's been found that delay in recognition has a dose-dependent response in terms of increasing mortality and length of stay. But I would also argue, actually, that delay recognition is almost unavoidable in the modern hospital. It's not only because the patients are getting older, but the patients we're seeing in the hospital are more complex and more acutely ill. There's more shift work and more burnout, as Maurizio says, so it makes it harder, actually, to see the trajectory of some of these patients. So this is a paper that's from my Toronto colleague that called Temporal Clustering of Critical Illness Events in Medical Wards. What they did was they looked at medical wards, and they looked at actually the likelihood of a patient on that ward dying, having a cardiac arrest, or needing an unplanned transfer to the ICU in the 6 hours if there was a previous patient on the same ward that had a similar deterioration. Well, if you look, actually, a patient in a ward in which there was a previous patient who had deteriorated had a 60-something% increased risk of having another patient on that ward deteriorating and going to the ICU. And if you look at actually, well, what about another ward? Ward A, somebody deteriorates. Do you see the same effect in Ward B? No, not necessarily. Now, I'm not suggesting that cardiac arrest is contagious. But what I am suggesting is that, if all your attention is on a patient who's deteriorating in your unit, it is so easy to miss another patient in the same unit who may be worsening. And that's easy to do because even after I'm busy seeing a complicated, deteriorating patient, even when I go back to the other patient, there's all this data now that I have to look at to see what's happening. And if you look at actually the modern hospital and the modern EHR system, there's over 200 to 300 data points per day on an average patient. Once they get into the ICU, it gets to be about 1,000. It is unavoidable to have information overload and to be able to miss things. So the problem is that when I have the entire hospital, that's a lot of beds. And it's like finding a needle in a haystack. So artificial intelligence, as you have heard several times today, and my colleagues and I have been locked in a room talking about this for the last 3 days, that's going to end up being the tool to help us find that needle in a haystack. And this is already being done. There has been multiple algorithms, using multiple machine learning algorithms to try to predict for patients with cardiac arrest, unplanned transfers to the ICU. And some of them are already being deployed in a hospital and integrated into the electronic medical system. And some of them have been actually tested to find that they seem to have an impact in terms of decreasing ICU transfers and decreasing mortality. Now, just to give you an example of actually how this can be incorporated to allow us to have situation awareness to monitor organ failure in the hospital, this is actually one that we had developed and validated called the approved score that looks at predicting for death or intubation at least more than 48 hours of mechanical ventilation. And this is another score that looks at identifying and predicting patients who may develop ARDS. Problem is, this was actually done a little before COVID, and then during COVID, everybody got so sick, and it was impossible for me to figure out what was happening and who was sick and who was getting sick in the hospital. So IT and data science was basically, like everybody else, did only COVID. So they developed this tool for me during this period of time, where we created a dashboard that looks at not only actually my hospital, but actually, I'll say, all 5 hospitals within my medical system. I can sort by department, COVID status, whether in the ICU, ventilator, and I can actually filter by these scores, the approved score and the ECART score, the ARDS I told you about, but also by SOFA. In this case, I have set the filter to give me only patients with SOFA greater than or equal to 2. And you can tell by each day how many patients actually had a SOFA score greater than or equal to 2. And if you click on any dot, it'll give you a list of all those patients, where they are, what their scores are, whether they're on a ventilator, and what else might be happening. And if you click on any one patient, it'll give you the scores as they're during the hospitalization so far. And you can see here, actually, this is the green is the approved score, and the blue is the SOFA score, and the red arrow indicates when they actually were admitted to the ICU. So this wasn't live yet, but you can see actually the SOFA score and approved score going up before they went into the ICU. Now, this only takes data from the electronic records, so data that actually you measure, like vital signs and so forth. But in the future, this is going to change. Because as we have heard about earlier today, instead of all these monitors, Heatherlee was saying, and that collects all this data, we're moving to a world where the monitoring can be wireless, integrated with video. What that means is, you know how you say, and I need to see this patient to see how sick they are, right? Well, now we're having the technology that will allow us to be able to do so. So, for example, actually, not only can you integrate wearable devices to measure your vital signs, but now you have cameras to see actually how the patient is behaving. Are they just lying still? They're agitated? They're behaving a certain way? Light sensors and infrared sensors that also pick up colors. Are they complexion changing? And these videos actually can pick up things like how did the patient look. And it's not that far off in the future, because as you can see here, the FDA has already cleared some of these devices for testing and for the market. And as we have talked about, and Matthieu was saying how some of these these algorithms are looking at titrations of levofed. Well, these can now be closed loop. So we know this from the ventilators in terms of automated weaning. They're not great yet, in my opinion, but that will only get better as they accumulate more data and learn. But there's also actually closed-loop systems to look at drug titrations. We talked about actually levofed, but this is an example using insulin for glucose control. So how do I see then the hospital of the future and how we are going to monitor organ failure? I think as these things developed, we're going to see a new system. Maurizio talked about actually how the ICU, and there'll be more of the hospital will be the ICU. I actually think that we're moving towards a system where basically any bed in the hospital can turn into an ICU bed with a higher level of monitoring. All you need to do is make sure that that bed gets those monitors, or you can wheel them to it, or network the entire hospital, which some hospitals are doing already. that means actually that patients who just need a higher monitoring, so DKA patients, sepsis patients that may be responding to therapy, or even actually patients that you're weaning on a ventilator and weaning on pressors, there's like low-dose testers and you're weaning them, they don't necessarily need to be in the ICU anymore. This can all be done through these beds at anywhere in the hospital, and there's a central command center where all of these information is fed back to a team, and then they can monitoring, and then this team then can then see which patient needs a higher level of care even beyond that, and send the critical care physician as well as maybe a nurse, respiratory therapist, to that bed to escalate, to do what any interventions that might be needed. So then what will actually the ICU be? The ICU is going to be these very specialized care unit in which actually patients there will be only patients needing certain interventions, devices, or procedures, or that is not easily do on the floor, that you need specialized staff and training to do. So like maybe ECMO or LVADs, or patients who have multiple organ failure that needs frequent interventions and on CVVH. This has implications for not just how the ICU is organized, but actually how healthcare system is organized. Because this could lead to actually regionalization of critical care. Because you can have that command center somewhere else and then monitor these patients and then move patients then to a hospital that has more specialized care for those who are sicker, especially if you can predict it. Which may actually, as we talked about, allow some more accessibility of critical care expertise to more areas where there are workflow shortages and specialty shortages. So how I see the future? I see critical illness in the future as a continuum. Throughout, when they present in the hospital, maybe to go into the ICU, maybe they don't, and also into recovery and when they ultimately go home. An ability to understand this trajectory and monitor for it along this entire continuum is going to be needed if we want to prevent critical illness and improve outcomes and help out patients. And I think actually the hospital-wide AI approach will be integral to that. So with that, I want to thank you for your attention.
Thank you so much, Michelle.
I think we have 5 minutes
I
to
have minutes.
grill the three speakers with a very hard question.
Yeah.
And my question is, we are educating the intensivists and the nurses and the pharmacists now. How can we attract them to this type of talks? Because this is really training them to do systems thinking. I mean, people are still flocking to the lectures on sepsis and ARDS when we need people to come to these types of talks, because you cannot just take care of your patient a day at a time because we're not fixing the problem. So any suggestions on how to make this more sexy, more exciting, so that more people will flock to this type of presentations?
I think the younger ones are actually quite excited about.
We don't see them.
Well, yeah. Well, I mean, locally, I mean, at Imperial, we get a lot of students. We teach them actually on machine learning in AI, and I'm aware in the US with Anthony Chang, there's a residency in AI in healthcare that's in the making. So I think.
But we need everyone. We don't need a subspecialized group of people. And Michelle and Maurizio, well, what are your thoughts?
So I think, with regards to our other team members in ICU, you mentioned respiratory therapists, nurses, and pharmacists, and so forth. So some of them are aware. I think as these technology kind of advance and becomes more concrete, I think it will become more accessible and more interesting to them. But I do think, however, that some of them are worried because in addition to the burnout that, would actually help them. Like, I think my nurses would be much more happy to spend less time twiddling the titration pump and more time actually talking with the patient. But a lot of my nurses also fear that this is going to take their job away, even as actually, we have a shortages of workforce. So I think actually with time, they will come and they will understand more as this becomes more concrete. But we do also need to do a little bit of work in educating them so that they can see that it is something that could potentially help and not necessarily be a threat and, keep them further away.
I think it's a great question, Leo, and I think actually there are two aspects here. One is the current generation of healthcare workers. Somehow I feel that maybe we are also a bit old to go into the details of machine learning and data science and so on. I was speaking with the Foundation Bruno Kessler in Italy, is one of the biggest data science institutes. And what they're doing now is actually teaching in high school these skills so that people become literate and maybe they can start even to program and to bring into this. So for that generation, I think we need to bring this into the high school curriculum, into the medical school curriculums as early as possible. And if we haven't done it, it should be done now. And we should not fight that generation, actually, with their own values. If their values is also that they want to learn this, but they want to work in a different way, I think really we need to accept this. Those are going to be the ones that are coming to intensive care, to work in our intensive care unit. For our current teams, I have the feeling sometimes that we are not taking the low-hanging fruit here. We have these great talks. If you're passionate about research, as us, it's great to talk about all of this. But actually, I've not seen talks about tutorials, for instance, on how you can use ChatGPT or generative AI to make the life of a doctor or a nurse to be easier, and so to start to see the value. I don't think we have shown the value to these people, and it's a bit scary when you talk about artificial intelligence because it gives you the feeling of computers and something you will not understand. And this is so broad that I think we need to show them the value for them.
Thanks.
We have 2 minutes.
To actually answer the
Okay.
question. So I came with two colleagues that were very new in their career, and they are at the sepsis talks and those sorts of things, because as the beginning of their career, their confidence level is very low, and they want to make sure they know this to the best of their ability of that hands-on do this. So I think combining from the previous section about our virtual simulation and expanding on our simulation and expanding our training in that space is something we could do right now for some of our younger in their careers so that they can start to broaden their horizons and think about these future things and these technology things and how to expand that into the next section of their career.
Thank you so much. I think we run out of time because there's another debate here in 2 minutes. So we hope to see you in the next couple of days.
Okay. Thank you to